Dr. Kende Elisha here. I'm going to go ahead and record this for quality assurance purposes. If you have any questions, please let me know. Throw your questions in the chat, email, or call, and I will guide you better. This is AANP examination content outline. It is slightly different from ANCC when it comes to the fifth domain. That is the roles, leadership, and ethical principles. We do have ethical principles on this exam. We do have some non-clinical stuff, but it's not as huge as ANCC. AANP is more clinical oriented. Okay, so in both exams, we still have to have something called what? Foundation, which is the knowledge. But for AANP, what is the content outline like, and how should we be approaching this review? Most importantly, what should be your focus and how should you be studying? So I'm going to guide you through that right now. Visit www.npcertificationacademy.com. That is www.npcertificationacademy.com. So at this time, we're now going to get started with the very first slide. This came straight from their direct website, okay, AANPSART.org. So Psychiatric Mental Health Nurse Practitioner Certification Examination is a competency-based exam. Let me grab my ink right here quickly. Competency-based exam, entry-level exam designed to assess clinical knowledge. Clinical, and they are what? Clinically what? Oriented. Very, very heavy-duty clinical stuff. And how many questions are on this exam? It's going to be 150. How are they scored? 135 is yours. 15 is for statistical purposes, and it doesn't impact your score in any way. So that means you run into some questions and you don't know what the answer is. You may be lucky. It may be some of those questions that doesn't need to add to your score. So we don't need to worry about those. All right? Now, what are the areas that we need to focus on? Everything. So what are the domains contained in PMHNP examination, the one by AANP? We have domain 1 through 4. In a way, 5 is kind of planted in somewhere there, right? Because as you diagnose, you have to treat, right? So diagnosis and treatment, so I call it like 5 different domains in a way. So they use the AANPPMHNP process, as you can see. The treatment kind of falls under intervention, which is not written here, but we can always assume they're present because you know that our intervention is the biggest part of, is a big part of what we do. That's one of the biggest part of the exam. So what is the first domain saying now? What items will you get from it? You're going to get 45 questions. Diagnose, you're going to get 28 questions. Plan, you're going to get 35 questions. Evaluate, you're going to get 27 questions. In total, we're going to be getting 135 whopping questions, right? This is the deal now. This assessment taps into almost every domain, so there is no reason to wonder why it's a lot on the exam. Listen, first of all, if we don't assess our patients well, it's a big problem because guess what? Our diagnosis will be what? Will be off. If we don't diagnose our patients well, then we're going to be planning on nothing, or our plan is going to be off. If we don't plan well, because it trickled all down from assessment to diagnosis to planning, now implementation, you're probably going to be given the wrong medication. So eventually we're going to have a bad outcome, which is the evaluation. So our assessment have to be on point. So that's number one explanation for this. Now, number two explanation for this is, as we're talking about assessment, what are the components of assessment? Listen, we have to think about, okay, what are the components of psych assessment? How do you document things? What goes under what? Neuropsych assessment, right? That's one aspect. Another aspect is what? Psychopharmacology assessment. Now, with psychopharmacology assessment, what does that mean? Well, we are now providers, don't forget. We went from, maybe you don't have to go through that sequence, but the sequence is you go from what? CNA to LPN and then to APRN. So we are on the top ladder. You've reached the pinnacle of your career. So it makes sense to expect more. So if a CNA exam will ask you, do you know where the pulse is located? The LPN exam will ask you 2 times that. Do you know where the pulse is located? And do you know how to palpate it? Now, the APRN will take you to another level. Do you know where the pulse is located? One. Do you know how to palpate it? When you palpate and something goes wrong, do you know how to fix it? Do you know what to fix it with? If that medication didn't work, do you know what else to do? Can you see how this is broad? So we should be thinking like this and not stay on the surface. You also have to be careful what kind of questions you are practicing. So we have a lot of questions for you to do in Canvas. Please don't go from review to review. Don't shop around for questions. There are no exam questions out there. You have to know your content because we don't have any strategy without content. You must understand your content, build your knowledge base, and you're going to be okay on this exam. It is a promise. Besides, whatever you don't learn right now, you may be stuck never learning it because once you pass your boards, you move on, you start working, and that's it. It gets passed on to the dump. We don't want to do that. You want to learn it right now and own it for life. So what else comes under assessment? We also have what? We also have our scales. Your patient comes in, you want to get a baseline. Of course, your scale falls under that. So how should you be thinking about scales? Think about it. If you have a patient, okay, that, let me say you work in critical care unit, and the patient tell you, hey, Miss Marie, I have pain. Wouldn't you be asking and say, okay, tell me, how bad is your pain? When you now get that scale all squared away, you are not able to put them what? You are not able to put them in the right treatment order. You are able to assess, do I need to give Tylenol first? Or this is beyond Tylenol, do I need to go down to Percocet? So that is kind of similar to the scales that we use in psych. We use our scales to gauge and to also plan treatment. Does it make sense? Now, it is not set on stone because not every patient knows how to feel it well. But it looks like I'm spending too much time on this domain one. Let's keep it moving. So it's going to be the highest number of questions. It's going to tap from every domain. So that means you have to know all your domains. You have to know your neuro. You have to know your pharm because we're going to tap from it. We have neuropsych assessment. We have psychopharmacology assessment. We have scales assessment. We have communication assessment. How are you addressing your patient? When they come into you, are you using open-ended questions? Are you using closed-ended questions? Are you adopting some concept from communication like the assertive style communication? Are you using motivational interviewing technique? Those all fall under communication and assessment as well. What about the diagnosis? With the diagnosis, you cannot escape something we'll call what? The DSM-5TR. The DSM-5TR is just a way for us to nail our patient's diagnosis. We have to be able to diagnose a patient before you can treat it. So a lot of us, we want to undo the pharmacology first, but that's not the first place to go. It's a big mistake. We need to nail this down too, but diagnosis, you gotta know it. Like it's not even a choice. Forget about board exam, talk about real life, think about real life. You must be able to have the right diagnosis to take care of your patient. Planning, that kind of falls right under that. Evaluation, and then intervention is somewhere around here for sure, but we can always integrate that with diagnosis. And then you want to evaluate, see the process and see where whether everything is being done smoothly. Now, the next slide we're going to talk about is the category. What is the breakdown of your exam? Which side or what area should you focus on the most? Infant and child, they say 8 items. Pre-adolescent, 11 items. Can you now see the population? Can you see why we focus on adult a lot? Adult is 67 whopping, guys. Maybe I should put this one, I guess, I don't know. Maybe I should put a smiley face. 67 whopping questions, guys. So it makes sense. If I have to take a chance in my life, I'm going to take a chance with adults. If I'm crunching for time, I'm not going to worry about these babies. I mean, in real life, you're going to worry about them, but I'm saying also the brain can only take so much. So I'm going to definitely go heavy on the adult first. So as I'm talking about diagnosis, I'm focusing on adults. As I'm talking about implementation, I'm focusing on adults. As I'm talking about, anything, assessment, adult. And that is the breakdown of the test. So what about the domains and tasks? Domain 1, got to know how to assess, evaluate therapeutic alliance, perform comprehensive psychiatric evaluation, conduct mental status exams and risk assessment, gather all collateral information from relevant sources, order and use evidence-based instruments, diagnostic tests, screening tools, right? Assess readiness for change and barriers to care. The next domain is going to be domain 2. What should we be focusing on? What should we be targeting? We must be able to know how to interpret result of tests. We must be able to screen to inform diagnosis. We must be able to formulate differential diagnosis based on subjective and objective data. We must be able to do what? Recognize anything that is urgent. And we must be able to prioritize diagnosis. And we must be able to do what? Establish primary and secondary diagnosis. And domain 2 continues with interpretation of results, formulating differential diagnosis according to DSM-5 TR and so on. Domain 3, what does it talk about? We must be able to develop a collaborative patient-centered care plan based on best evidence. We must be able to provide psychopharmacotherapy information. We must be able to select and prescribe medications. We must be able to offer psychotherapeutic interventions and psychoeducation. We must be able to collaborate with other healthcare providers. We must be able to refer to specialists as necessary. We must be able to ensure continuity of care and manage transition. I can tell you right now, collaboration answer on the test generally wins. So pay attention to that. In addition, you will not be getting a lot of referral questions on AANPPMHNP exam, just to let you know. Domain 4 talks about assessing the efficacy of plan of cares, monitor medication side effects and patient adherence. We must learn to adjust plan of care based on patient needs and outcomes. We must be able to engage in quality improvement and adhere to ethical and legal standards. Now, that is the last domain, the evaluate. So how do we apply knowledge? What should we apply to those knowledge areas to help us solidify our, learning? We must have the basic understanding of A&P. They are not asking you about A&P, but we must know neuroanatomy. We must know neurophysiology. We must know the neurotransmitters and how they affect our patient's brain. And then we're going to connect that dot with psychopharmacology. Listen, let's pretend that we have 3 cups in here. These 3 cups right here, we have what? Cup A, cup B, and cup C. Now, cup A, we're going to call it neurotransmitter. Cup B, we're going to call it what? Psychopathology. Cup C, we're going to call it what? Pharmacology. So now, what am I trying to come up with here? So let's say that in our brain, we're supposed to have a certain level of chemical, right? In our brain, we're supposed to have a certain level of chemical. So now we have this chemical right here. Normal brain, we need to have our level at level 2. But something happened, whatever it is, our level dropped to level 1. Guess what we have done? Now we have a patient that is looking like this, depressed. Because let's say the chemical is serotonin, for example. So because the serotonin is down in the brain, it's going to lead to depression. And then you, as the provider, you're standing right here, monitoring your patient, trying to think of what to do. You do your assessment and you figure out, oh my gosh, the level is only -1. The level is -1. Based on my assessment, the serotonin is low. I have to look for something to do what? To bring the patient back up. And that is where SSRI comes in play. With SSRI, you want to drop it in here, in this patient, to achieve what? A new patient with a new face, a smiley face. So you now brought your patient up from level 1. You are able to bring them from level 2 because you have replenished the chemical that was lacking from this box B. Are we all making sense out of it? That is all we're doing. So for every neurotransmitter issue that we have, we must connect the dots and say what pathology is it leading to. That will now guide us on what chemical to use to replenish that pathology. Please drop me some yes in the chat if you understand this concept. This is not a chemistry class, I get it, but I promise you right now, this is all we're doing as clinicians. Psychotherapy also helps. Research have shown that combination of therapy plus pharm is a miracle worker. Okay? So that is what theory says. What type of therapy should we focus on? Individual, group, and family. That's it. Now, assessment and diagnosis, clinical interviewing, mental health screening tools, diagnostic decision making, care practices, harm reduction, trauma-informed care, cultural awareness, and age-appropriate care. Then we also have professional role, evidence-based practice, ethical issues, interprofessional collaboration. Now, disorders that will be in the examination was broken down into 3. Some are not frequently tested, some are frequently tested. Now, the ones that are frequently tested are right here that you would definitely see on the exam. And guess which population we're going to be focusing on the most? Adult. We're still going to touch upon peds though, because we need to worry about what? Adjustment disorders, ODD conduct, those are all peds, and that will be on the test. So this depressive disorder, anxiety disorder, bipolar related disorders, trauma and stressor related disorders, substance and related and addictive disorders, sleep-wake disorders, personality disorders, schizophrenia, and this one says somewhat. Schizophrenia, another psychotic disorder. We're still going to hold on to schizophrenia. Neurodevelopmental disorder, autism will be on your test for sure. ADHD and ADD will be on the test. Intellectual is not very, very common. Obsessive compulsive and obsessive compulsive personality are 2 different things. They will both be on your exam. DMDD, conduct 100%. You can be guaranteed to have this on your exam. Neurocognitive disorder, Alzheimer's, delirium. Do you know how to separate them? What about your breathing related and sleep disorders will be on your exam. Gender dysphoria, sexual dysfunctions, somatic symptom related disorders will all be on your exam. Feeding and eating disorder is somewhat, so you can't say it is not going to be on there. All right. So that is pretty much it for the exam content outline for AANPPMHNP certification examination. All right, Dr. Kehinde Elisha speaking here, founder of MP Certification Academy. Today we're going to be going through psychotherapy Q&A. So psychotherapy, we always say it means talk therapy, but there is also an integration with, for example, when we have pharm, okay, that's a therapy. When we have psychotherapy, that is also a therapy. This we are talking, this we are using chemical, okay, to heal, right? So now, what the deal now is, when we use words to heal people, it is also, technically like medicine, and it also have its own class. So, for example, when we talk about, individual therapy, for example, under individual, we have CBT, we have DBT, we have psychoanalysis, we have existential therapy, and so on and so forth. Now, existential is what I meant, not experiential. Now, under pharm, on the other end, we say we're using chemical. Under that umbrella, we're going to have SSRIs, for example. Under the SSRI, we have what? Fluoxetine, paroxetine, sertraline, and so on and so forth. They are all under SSRIs, right? That's the same way now. So when we think about pharm, we have to think about psychotherapy that way. So how should you be reading your psychotherapy question on the exam? So let's jump right in here. Dr. Kehinde Elisha speaking here, founder of MP Certification Academy, nurse-coach@gmail.com or www.npcertificationacademy.com. A 32-year-old woman presents with persistent anxiety related to work performance. She often thinks, if I make one mistake, I will get tired, and avoids taking on new responsibilities. She is tearful and reports somatic symptoms such as heart palpitations and restlessness. The provider chooses an evidence-based therapy that targets negative, there's a mistake here. Just say negative thoughts and behaviors. Now, the question now is, which of the following therapeutic techniques is most appropriate for challenging this patient's automatic thought? A, thought stopping. B, Socratic questioning. C, free association. D, validation. Providers, drop your answers in the chat. I'll be taking a look at what you picked. That target negative thought. If I make one mistake, I'll get fired. Right? And avoid taking on new roles. Well, I see why you're thinking thought stopping, but let's pick whatever we pick. Let us connect the dot with what the case is talking about. This is talking about which of the following therapeutic techniques is most appropriate for challenging the patient thought. So that means you as the provider, what are you going to do? You can't use thought stopping in this situation. You're using Socratic questioning. Socratic questioning is a core CBT technique to challenge cognitive distortions and help the patient examine the validity of their beliefs. So We have CBT, that is what we have to use for this patient, but there are techniques that you as the provider have to use, and that will be what? Socratic questioning. Socratic questioning. That will help affect or target those thoughts. Now, thought stopping is also a good thing. It's just not the best answer for this case based on the scenario that we got. Does it make sense? The thoughts will not stop automatically. But when we use Socratic questioning, it's going to challenge those distortions and also help examine validity. You may even have something that sounds like, what do you think about your job? Why do you think that is? You won't use why questions, but you want to explore deeper. Socratic questioning will explore deeper why your thought is going that route. Let's look at question number 2. Is a 24-year-old woman with borderline personality disorder present with emotional instability, self-harming behaviors, and chronic feelings of emptiness. She reports difficulty maintaining relationships and says she either loves or hates people in her life. The provider recommends a structured therapy that includes mindfulness, emotion regulation, distress tolerance, and interpersonal effectiveness. What is the primary focus of DBT? A. Restructuring automatic thoughts. B. Teaching patients to avoid emotional triggers. C. Balancing acceptance and change. D. Exploring unconscious conflicts. What do we do? First of all, DBT, when I say DBT, you say what? You say borderline. So think of people that have borderline personality disorders. They are emotionally reactive. So we have to use DBT a lot of times to support them. That's supposed to give you a guide to this answer. So what do you think this answer is? So, a 24-year-old with borderline present with emotional instability, self-harming behaviors, chronic feelings of emptiness. She reports difficulty maintaining relationships, says she either loves or hates people in her life. The provider recommends a structured therapy that includes mindfulness, emotion regulation, distress tolerance, and interpersonal effectiveness. Restructuring automatic thoughts. When do you do that? We do that with CBT. Teaching patients to avoid emotional triggers. What do you do? Well, that's a good thing. Teaching them, but that falls mostly on what? That falls mostly with our, honestly, PTSD, EMDR. What about exploring unconscious conflict? That falls with what? That is a technique for which one? Exploring unconscious conflict. That would be something like psychodynamic, if you think about it. So, balancing acceptance and change. C, final answer is what is left. Balancing acceptance and change. How much change can you cope with? Is that why you are so dysregulated? Why are you not maintaining relationships? So DBT focuses on accepting patients as they are while also helping them to change maladaptive behaviors. So that's where the balancing acceptance and change kind of comes in. It is focused on maladaptive behaviors. Let's look at the next question. A 40-year-old veteran with PTSD reports recurrent nightmares and flashbacks after exposure to combat. He avoids reminders of trauma and feels emotionally numb. The provider recommends a therapy that uses bilateral stimulation to reprocess traumatic memories. Which component is central to EMDR therapy? A, guided imagery. B, dream interpretation. C, bilateral stimulation. D, free association. What do we think? EMDR. This is actually covered in class. What is the technique for EMDR? What is central to it? Guided imagery, dream interpretation, bilateral stimulation, free association. We know the final answer is going to be bilateral stimulation. C, final answer. EMDR uses bilateral stimulation like eye movement. Remember, again, it is called what? How do you define EMDR? How do you define EMDR? You define EMDR by saying what? It is eye movement, desensitization, and reprocessing. So eye movement, tapping, while the patient recalls trauma to reduce emotional distress. So eye movement uses bilateral stimulation. All right, that is psychotherapy for you now. The more the content, the better for you. So now a 58-year-old man who recently lost his job reports feeling depressed and without purpose. He states there is no point going on now that I have nothing to live for. The provider recommends a therapy developed by Viktor Frankl that emphasizes finding meaning even in suffering. What is the main goal for logotherapy? A. Resolving unconscious conflict. B. Enhancing interpersonal effectiveness. C. Discovering meaning in one's experiences. D. Challenging cognitive distortions. Providers, what do we think the answer is here? Don't forget, logotherapy is close to existential therapy. So we are looking for what? We're trying to find meaning and purpose. C, final answer. Logotherapy helps patients find meaning in life, even during adversity, to foster psychological and resilience. Let's look at question number 5. The next question, I think, is 5. I lost count. A 45-year-old woman reports feeling empty and unfulfilled despite career success and a stable marriage. She questions the purpose of her life and fears dying without making impact. The provider uses a therapy approach focused on freedom, responsibility, and creating meaning in one's existence. What existential concept is most relevant to this patient's presentation? Providers: A. Cognitive restructuring. B. Transference. C. Existential vacuum. D. Defense mechanism. You have to look at the case to match your answer. And this concept, we'll really talk about it, but just give it a shot. Because a part of that concept is also relevant, right? She questions the purpose in her life, okay? That should clue you into what type of therapy normally. Questions the purpose. What is my purpose? Why am I here? What is my purpose in life? That's supposed to be existential therapy. All right. So existential vacuum is the closest thing that you can pick. C, final answer. The existential vacuum refers to feelings of emptiness and meaninglessness, often treated by helping patients create meaning and take responsibility for their choices. A provider sees a family where the 12-year-old son is acting out at school. During this session, it becomes clear that the mother confides in the son about her marital dissatisfaction, and the father is emotionally withdrawn. The son seems to take on the role of the mother's emotional supporter. The family role of the son is playing in this scenario is what? A. Scapegoat. B. Mascot. C. Parentified child. D. Lost child. Lord have mercy. Those options are ridiculous. Parentification, a parentified child. This happens more often than not, right? A 12-year-old son is acting out at school. During this session, it becomes clear that the mother confides in the son about her marital dissatisfaction, and the father is emotionally withdrawn. The son seems to take on the role of the mother's emotional supporter. So that is parentified child. That is not good. So we have to be careful how much we expose these kids to. There is only so much their brain can take. A parentified child takes on emotional or physical responsibility typically handled by a parent, often due to family dysfunction. It is not normal. Now, a 35-year-old woman presents with anxiety triggered by family visits. She feels overwhelmed by her family's needs and often sacrifices her own. The provider assesses a level of differentiation from her family and notes a pattern of emotional fusion. According to Bowen's family system theory, the concept best describes the patient's inability to separate her emotional functioning from her family's. A. Differentiation of self. B. Projection. C. Multi-generational transmission. D. Emotional cutoff. Drop your answers in the chat, please. All right, I'm checking the answers right now. All right, excellent, 100%, 100%. So the final answer is going to be A, differentiation of self. We know it's not projection, it's not motivational, it's not emotional cutoff. So it's anxiety triggered by family visit. She feels overwhelmed by her family's needs and often sacrifices her own. That is very, very common around this part of the world. or even to us that are here from people abroad. We take on so much that we can't even find our own self. Differentiation of self refers to what? The ability to separate one's thoughts and feelings from those of the family system. Low differentiation leads to emotional fusion and anxiety. Let's take a look at this question. A 14-year-old adolescent is brought in by his parents due to defiance and school refusal. During the session, the therapist notices, or the PMHNP, we are also the therapist, notices that the adolescent interrupts the mother frequently, and the mother defers to the child rather than a spouse. The father is emotionally distant and rarely speaks. The therapist plans to realign the family subsystems and strengthen parental authority. Which intervention is most aligned with structural family therapy? A. Helping the family identify rational beliefs. B. Reframing trauma narratives. C. Strengthening the boundaries and family hierarchy. D. Exploring existential purpose in parenting. The intervention is most aligned with structural. Don't forget hierarchies. That should be your clue too. Strengthening boundaries and family hierarchies. C. Final answer. Structural therapy emphasizes realigning subsystems like parental versus child and adjusting family boundaries, rigid, diffuse, or clear, to create healthier interaction patterns, because there is something wrong here. Something is really off. They are not communicating very well here. A 10-year-old boy has been bedwetting despite no medical cause. The provider notes that the parents respond with excessive attention and worry, which the boy seems to enjoy. The provider suggests paradoxical intervention, telling the child he must stay up every hour at night to make sure he wets the bed. Paradoxical is they come in with a problem, you're going to tell them to go back and complete and do the same problem. Which strategy technique is being used? A. Circular questioning. B. Paradoxical directive. C. Free association. D. Behavioral activation. What do we think? We already saw it. It's kind of, exam will not be like that though. It's kind of already thrown in there. Paradoxical intervention. That's called paradoxical directive. That is a technique. Strategic therapy often uses paradoxical interventions. Remember, we went over this content already. We went over four family therapies: strategic, structural, existential, solution focused. Strategic is the one that uses paradoxical directives, where the therapist prescribes the phenomena or symptom, creating what? Awareness, and often reducing the undesired behavior. Because the patient will not be like, no, heck no. I refuse to go there and pee on myself, or I refuse to go there and keep worrying. They will now, their ego state will kick in and they will stop automatically, and they will yield to whatever you ask them not to do. A couple comes in after recent marital conflict. The provider avoids exploring the origin of the conflict and instead asks, can you tell me about a time this week when you two got along better, and what will be different when the problem is solved? So, which of the following best represent the core technique here of solution-focused brief therapy? A. Transference interpretation. B. Miracle question. C. Emotional flooding. D. Reenactment. Now, think of it as the content that went over in class. It's about a green check. So if you were to, no, maybe not green check. If you're to look at your, student loan today and it's no longer there, how would you know a miracle took place? That is a miracle question. That's the same question that they are avoiding here. The provider avoids exploring origin of conflict and instead asks, can you tell me about a time this week when you two get along better? Solution, miracle question. B, final answer. You have to understand the content first for this to make sense. At NP Certification Academy, we don't joke with content. I recommend that you go solidify your content if you're confused right now with my analysis. So, solution-focused behavioral therapy focuses on strengths and solutions. Now, the miracle question is used to help clients visualize what life would look like if the problem were gone. Empowering solution-focused action. Next question. A family present with therapy after recent loss of their father. The teenager has withdrawn emotionally, and the mother appears emotionally distant. The therapist encourages the family to express their feelings directly and uses self-disclosure to build a genuine relationship. What is the hallmark of experiential family therapy? A. Direct interpretation of unconscious drives. B. Use of metaphor and paradox to shift patterns. C. Promoting emotional expression and authenticity. D. Developing cognitive behavioral coping plans. Please drop your answers in the chat. Writers. This one is pretty straightforward though. So promoting emotional expression and authenticity will make sense here. The question is saying the teenager has withdrawn emotionally and mother appears emotionally distant. The therapist encourages family to express their feelings directly and uses self-disclosure to build genuine relationship. So the hallmark of experiential therapy is going to be what? To promote emotional expression and authenticity. C, final answer. Experiential therapy focuses on emotional experiences and vulnerability. Let's look at the next question. It's a 17-year-old female. 17-year-old is a female keyword. Is brought in for therapy due to increased argument with her mother. The therapist observed that the mother and daughter have formed a coalition against the father. All right. Remember, we talk about these concepts too. Who is described as passive and disengaged. Now, the therapist notes enmeshment between the mother and the daughter and disengagement between the father and the family unit. Which structural concept explains the coalition between the mother and the daughter? A, differentiation. B, triangulation. C, subsystem boundary. D, across generational alliance. Just know that for the purpose of the exam, honestly, triangulation will make sense. Okay. All right. For the purpose of board examination, I'm going to focus on triangulation. Okay. However, we are picking some. The source of this content picks something else, but we're going to what you're going to see on exam is going to be triangulation. So that's what we're going to focus on. The source of this content, they are going for the cross-generational alliance because it is the child conniving with one parent. Okay, but the exam will not be that specific. The exam just wants 3 people involved in a particular issue, regardless of the age, and then we call it triangulation. So for this question, I'll just go with B. I'll go with B. But also, if you don't see B on the option, definitely D is the final answer. All right. Boy is brought in for refusal to eat. The parents constantly argue over how to handle the behavior. The therapist notes that the boy's symptom is refusing food is as a way to gain control and unite the parent. The therapist revises an intervention where parents are instructed to ignore the behavior for 8 hours. What is the symptom serving in strategic what is the symptom serving in strategic family therapy? A, neurodevelopmental deficit. B, an unconscious expression of trauma. C, a communication tool to control family dynamics. D, a need for behavioral reward reinforcement. Drop your answers in the chat, please. And I know you're looking at therapy now that, oh my gosh, these questions are so hard and stuff. You'll find out that it's about concept. It's like definition of stuff too. 13-year-old boy refused to eat. Parents constantly argue over how to handle the behavior. Therapist notes that the boy's symptom is refusing food is a way to gain control. What do we think? Drop your answers in the chat, please. All right, it's a communication tool to control family dynamics. Okay. It's a communication tool to control dynamics. It is not a trauma related. We didn't get any question. There is no deficit here. and D is not applicable. So now, strategic therapy views symptoms as functional and communicative, often serving a purpose in the power structure or alliance dynamics of the family. A 30-year-old presents with ongoing conflict of his partner. Rather than exploring the root causes of the relationship issues, the therapist asks, what's one small thing you did this week that went well? And on a scale of 1 to 10, how close are you to resolving the issue? Which solution-focused technique is this? So this is very, very straightforward, but you have to know the content. Scaling question, Socratic question, and thought challenging. Circular question, and we know that it's a scaling question. Scaling question on a scale of 0 to 10, 10 being the worst. How anxious about your exam that is about to come up? That is what we're asking. That's scaling question. A is the final answer here. I saw the answers already before I even said anything. So you saw it straight up because you know what the content is. Scaling question helps clients to evaluate their own progress, readiness, or emotional state in SFBT, offering a measurable and empowering framework. Let's take a look at the next question. A provider sees a family in which parents express frustration about their withdrawn teenage son. The therapist observes rigid communication patterns and emotional suppression. During a session, the therapist uses family sculpting, asking each family member to physically position each other to represent how they feel in the family. What is the goal of family sculpting in experiential therapy? A. Restructure the family hierarchy. B. Externalize the problem behavior. C. Visually and emotionally express internal family roles and dynamics. D. Identify distorted cognitive beliefs. Drop your answers in the chat, please. All right, so you want to visually and emotionally express internal family roles and dynamics. The content's going to guide you as to what to pick. Experiential therapy uses creative symbolic techniques like sculpting to increase awareness of family dynamics, foster emotional expression, and stimulate change. Next question. A 28-year-old woman presents with anxiety. She reports that every time she visits her parents, she feels overwhelmed, guilty, and changes her plans to please them. She says, I just can't say no to my mom. I feel like I am 12 again when I go home. She's successful at work but crumbles emotionally when in her family's presence. Which Bowenian concept best describes patient experience? A. Emotional cutoff. B. Multi-generational transmission process. C. Differentiation of self. D. Triangulation. This is Bowen question, frequently tested on the exam, and understanding the concept was going to get you through. Please drop your answers in the chat. All right, we know the final answer is going to be differentiation of self. Differentiation is the ability to maintain a sense of self while in close emotional contact with others. Now, this patient struggles to separate our identity and emotional responses from our family's expectations. The next question. A 10-year-old boy begins having school refusal and stomach aches. During therapy, it becomes clear that the parents have frequent arguments but avoid discussing their issues directly. Instead, they both focus attention on boy's symptom. The provider suspects the child has become part of dysfunctional communication triangle. What Bowenian concept explains the direction of conflict onto the child? A. Enmeshment, projection, triangulation, scapegoating. So we have A. Enmeshment, B. Triangulation, projection, C. Triangulation, and D. Scapegoating. What will you pick? Please drop your answers in the chat. This is all in my Crystal Clear edition, first edition. Crystal Clear edition, psychotherapy, first edition. There is no way to go over everything in class. That's why I gave you all the content. Please make the content count. You got to soak yourself in the content. You will not regret it. Okay? So this is a classic example of triangulation. Classic example of triangulation. C, final answer. Triangulation occurs when two family members in conflict pull in a third to reduce stress in the system. The child becomes a symptom bearer distracting from marital issues. Okay. So the next question, a provider is working with a 35-year-old man with a history of emotional detachment. His father was cold and authoritarian, and his grandfather was a military officer who discouraged emotional expression. The therapist identifies a pattern of emotional distance across generations. Which Bowen concept best applies to this case? A, family projection. B, multi-generational transmission process. C, emotional cutoff. D, fusion. What do we think? Think about the generation to generation. 35-year-old with a history of emotional detachment. His father was cold and authoritarian, so transfer that kind of training to him, right? And then his grandfather was a military officer, so that makes sense that his own father was like that. And he doesn't like people expressing emotions. So now he's going to be going around too without emotional expression. That is multi-generational transmission process. B, final answer. This concept refers to passing down patterns of emotional functioning like detachment or low differentiation across generations. A 30-year-old woman presents with depressive symptoms. She states that she hasn't spoken to her family in 5 years due to unresolved childhood trauma. They just don't understand me. I had to cut them off for my sanity. However, she continues to feel emotionally reactive when they are mentioned. What is the best Bowenian concept to describe this situation? A, triangulation. B, differentiation. C, emotional cutoff. D, enmeshment. Providers, what do you think? This is gotta be what? Emotional cutoff. I don't want to hear your voice. I don't want to hear your name. I don't want to hear their name. You have cut them off emotionally. C, final answer. Emotional cutoff is a way individuals attempt to manage unresolved family issues by severing emotional contact. However, this doesn't mean the emotional ties are gone and often reflects low differentiation. Firstborn child is consistently praised by a parent for being responsible and mature, while the younger sibling is seen as the wild one. The younger sibling, now a teenager, presents with oppositional defiant behavior and low self-esteem. The provider explores the pattern of parental expectations based on birth order. The two Bowenian concepts that best describe are best reflected in this case. A, fusion and cutoff. B, family projection process and sibling position. C, triangulation over functioning. D, scapegoating and detouring. Please drop your answers in the chat. So this is talking about a younger sibling, now a teenager. Now they're going to feel untreated, right? I tell parents all the time, even if one of your kids are doing really well in school, don't go knocking out the other kid. Don't go talking down on the other kid. It affects their self-esteem. It brings them down. When they get down there in the dump, it may be hard to come back up. So let's be careful. And if your kid is not bright in an elementary school, I am a living testimony. Trust me, they're going to pick up at some point in their lives. Just they need some encouragement. Maybe high school or something. So family projection process and sibling position. B, final answer. Parents often project their anxieties onto one child, reinforcing fixed roles. Sibling position also plays a role in shaping family expectations and dynamics. Next question. A 28-year-old woman presents with symptoms of anxiety. She reports that when she visits her family, she quickly becomes overwhelmed and tends to change her plans to meet her mother's expectation. I feel like I lose myself when I'm around them, she says, although successful at work and struggles to make independent decisions around her family. What concept best explains this client experienced emotional cutoff, multi-generational transmission process, differentiation of self, and triangulation. Providers, drop your answers in. This is differentiation of self, similar to what we saw earlier. Dr. Kehinde Elisha speaking here, founder and CEO of NP Certification Academy. To sign up for our review, www.npcertificationacademy.com, or if you pass your boards already, visit www.confidentprescriber.com. To reach out to us, nurse-to-nursecoach@gmail.com. All right, we're now going to move on to the next. Okay, let's quickly go ahead and take this question. And let's read the rationale. So now, differentiation of self. Differentiation refers to an individual's ability to maintain their identity and regulate their emotions while staying emotionally connected to other people. Now, the patient is emotionally fused with our family and lacks the internal boundary to separate our values from theirs. You see how she's going to continue to have problems. Emotional cutoff. This refers to severing ties with family to avoid emotional pain, which is not evident in this case. She is still engaged with her family. Multi-generational transmission process explains patterns passed through generations and doesn't directly address our current identity struggles. Triangulation. This involves bringing in a third party to stabilize the relationship, which isn't happening here at all. All right, 10-year-old boy begins experiencing stomach aches, refuses to attend school. This is similar to what we just got. All right, triangulation. 35-year-old man presents a pattern of emotional relationship. This is, I don't think this looks like we did this before too, but let's just take it. Okay, so a 35-year-old man presents with a pattern of emotional distance in relationship. His father was an authoritarian, emotionally cold. The grandfather was described as a rigid and unexpressive. And of course, this emotional style is now affecting his marriage. Which Bowenian concept best explains the intergenerational pattern? A, family projection. B, multi-generational transmission process. C, emotional cutoff, D, fusion. And that's one thing. This is not only affecting the kid, now it's now affecting the entire family. Emotional distance in relationship, they don't even see anything wrong with it as they do it, but people around them keep observing them and they pull back too and move away. Does it make sense? So, drop your answers in the chat, please. All right, thank you so much for connecting with me here. It is multi-generational transmission process. It's similar to the one that we saw when they said the grandfather was a military, and then they told him to keep a straight face, cold face, wet face, I don't know. And now the kids don't know where to put their face too. B is the final answer. So the concept describes how patterns of emotional functioning are passed on from generation to generation. The client has inherited a style of emotional disengagement likely rooted in previous generations. Now, family projection. This focuses on more on how parental anxiety is projected onto the children, not intergenerational patterns. Emotional cutoff. This one is the patient has not avoided family contact. He is reenacting patterns, not avoiding them. Fusion. While the man may have low differentiation, there is no indication of enmeshment. All right, a 30-year-old woman presents with depressive symptoms. She has not spoken with her parents in 5 years, stating, "I had to cut them off. I just couldn't deal with them any longer because of the emotional toxicity." So now, despite the cutoff, she becomes tearful when discussing them. She feels controlled by their expressions. Which Bowenian concept is most applicable? Triangulation, differentiation, emotional cutoff, enmeshment. It's a 30-year-old female. We saw the same question previously. It is an emotional cutoff. C, final answer. Emotional cutoff is a process of reducing or eliminating contact with family members to manage unresolved emotional issues. Though contact is severed, emotional reactivity remains the same. Triangulation, there is no third-party dynamic being used to deflect conflict. Differentiation. While low differentiation may underlie this, The behavior points to emotional cutoff specifically. Enmeshment. This involves overly diffuse boundaries and is more about closeness than emotional avoidance. See final answer there. In therapy, a mother describes her two daughters. The older one is the mature, responsible one. The younger one is always emotionally and dramatic. Now, this is repeating again, right? We already know what this is all about. Putting one down to raise the other up. What do you think is likely going to happen here? This will be a family projection process and assembly position. Same thing as we went over previously. And we have to pay attention to that. We don't need to praise one kid for the other or put one kid down for the other. The family projection process refers to how parents project their anxiety onto a specific child. Sibling position refers to how birth order can influence personality and family expectations. For example, oldest is responsible for the youngest is responsible but then it gets into their emotional states too. Fusion and cutoff. There is no sign of emotional fusion or avoidance here. Triangulation and overfunctioning. The child is not being used to mediate conflict, and there is no caregiver functioning described. Scapegoating and detouring. While scapegoating could apply, those are not Bowenian core concepts. Projection and sibling role is more accurate here. In a support group for individuals with major depressive disorder, a 29-year-old woman tearfully shares that she feels alone and ashamed in her struggles. Another member responds, "I feel the same way every morning." The member begins nodding in agreement. Which Yalom therapeutic factors is most clearly demonstrated in this moment? A. Catharsis. B. Universality. D. C. Installation of hope. D. Altruism. Providers, drop your answers in the chat. Whatever you're going through right now, we're going through the same. You are not alone. Universality. B. Final answer. Universality occurs when group members realize that others share similar experiences, reducing feelings of isolation. Catharsis refers to emotional release, which may occur, but the main point here is shared experience. C. Installation of hope. This involves seeing others improve, not just relating to their similar struggles. Altruism involves helping others, but no helping behavior is shown here. So altruism is to pretty much give the part of yourself to somebody else. So a mother attends a NAMI family to family support course after her adult son was diagnosed with schizophrenia. She learns about symptoms, treatment strategies for communication. She reports feeling empowered and less helpless in her role. What is the primary goal for NAMI's family psychoeducation program? A. To train family members to diagnose mental illness. B. To provide legal advice for families in crisis. C. To educate and empower families to support recovery. D. To replace psychiatric care with family coaching. Please drop yours in the chat. Family psychoeducation program. So we know it's supposed to educate and empower families to support recovery. C is the final answer. NAMI aims to inform and support family. Don't forget also an advocacy role. Improving outcomes by reducing caregiver stress and promoting understanding. Families are not trained to diagnose. NAMI does not provide legal services. It complements, not replace professional treatment. The next question. A behavioral health clinic adopts SAM HSA's trauma-informed care model. Staff are trained to assume clients may have experienced trauma and changes are made to avoid triggering environment. According to SAM HSA's framework, which principle is most central to trauma-informed care? A. Encouraging clients to recall traumatic event. B. Diagnosis PTSD in all patients with trauma. C. Providing cultural competence medication counseling. D. Creating physical and emotional safety. Maslow's hierarchy of need. Safety for clients. Please drop your answers in the chat. All right. Thank you so much for participating. And of course, the final answer here is, I see many people dropping in the chat, D, and that makes a lot of sense. Creating physical and emotional safety for clients. That's SAMHSA trauma-informed care model. That is just the model. That's the framework behind it. So creating physical and emotional safety for clients. SAMHSA model is based on realizing and recognizing and responding to trauma while prioritizing safety, trustworthiness, and empowerment. Recording the next question, 41. During a routine visit, a 24-year-old college student screens positive for audit C for risky alcohol use. The provider uses motivational interviewing and says, "You mentioned wanting to do better in school. How does your drinking fit that goal?" What birth component is the provider using? A, screening. B, brief intervention. C, referral to treatment. D, cognitive restructuring. Please drop your answer in the chat. And that's the way they're going to throw you into a critical thinking scenario for your motivational interviewing technique, for your frames mnemonic, for your birth. And we know the final answer is brief intervention. Brief intervention, please. So you mentioned wanting to do better in school. How does your drinking fit into the goal? That component is brief intervention. B, final answer. The provider is using brief motivational discussion to help client or patient recognize consequences and enhance readiness to change. Screening with sound like this is already completed using audit C. C, with referral to treatment with sound like this will be used for more severe substance use. And then cognitive restructuring with sound like CBT technique, which is not a part of CBT. Okay, 35-year-old man with generalized anxiety disorder says, "I just want this thought to stop." The therapist helps him observe his thought without judgment and clarifies his values around being a good father, encouraging him to commit to actions aligned with the values even when anxious. What is the primary therapeutic process at work with ACT? A, challenging distorted thoughts. B, exposure and response prevention. C, values based on action and acceptance. D, enhancing insight into unconscious motives. The final answer here, drop in the chat. Let's look at the keywords again. I just want these thoughts to stop. The therapist helps him observe his thought without judgment. Observe his own thought without his judgment. So you want to clarify values, right, around being a father. That will be a value-based action and acceptance. Therapy is very, very, very broad. So I'm just trying to go deeper because there are more than 6 test versions. The more content we're exposed to, the better. If it's a content that we do not cover in class, you're going to grab the rationale right now as we go. I really hope that you are learning. The final answer here is C. Value-based action and acceptance. All right? So value-based action and acceptance. So ACT focus on accepting thoughts, feelings without avoidance, and committing to actions based on personal values. And the other approaches does not fit. All right? So I guess we're going to look into these other questions next time. But for right now, let's look into psychoeducation. For schizophrenia, use of psychoeducation is to help them understand symptoms, medication side effects, and relapse prevention. In bipolar patients, the use of psychoeducation is to help with mood monitoring, sleep hygiene, early warning signs. With somebody with anxiety or depression, coping strategies, cognitive distortions, stress management is the purpose and the use of psychoeducation. Substance use triggers, craving cycles, birth relapse prevention is the purpose of psychoeducation. For family therapy, the purpose of psychoeducation is to help teach family members about diagnosed and effective support roles. Okay, so then this is about Yalom principle, NAMI, SAMHSA's birth. And don't forget, we also have some therapies and technique here. For Bowen family therapy, the technique is differentiation of self. For Yalom group therapy, universality, ACT, cognitive diffusion, spirit, motivational interviewing technique, and so on and so forth. So that is just for like an activity that I actually incorporated into the set of questions. But we're not able to get through all of this right now. Dr. Kehinde Elisha speaking here, founder and CEO of MP Certification Academy. Thank you so much for connecting with us today. We're now going to end this content right here. We also have some more quizzes on Canvas. Make sure you do those quizzes on Canvas, please. We still have the TTM, Trans-Theoretical Model of Change, Contemplation, Pre-Contemplation, Preparation, Action, Maintenance. That will also be on your exam.
Don't also forget the Piaget, the Erickson, the health belief model, like the cues to action, perceived barriers, severity, susceptibility. We're going to continue to put a lot of content into you in class, but you got to put some time in to reinforce it. You will make it. This is why we are here to guide you. At this time, we're now going to go into some other domains, which is roles, leadership, and ethical principles. We are now done with psychotherapy. Thank you so much and have a wonderful day. Don't forget to reach us www.npcertificationacademy.com or email nurse-to-nursecoach@gmail.com. You can also call 347-901-6037. 99.9% pass rate. You cannot beat it. We support our students. Your 6 weeks, my 6 weeks may not be your 6 weeks. If you need extra time, don't forget we have extended package for $399. You will also get it for the same 6 weeks. Extension package is $399. All right. Thank you and have a wonderful day.
Speaking here is Dr. Kehinde Elisha, founder and CEO of NP Certification Academy. To reach us, nurse-to-nursecoach@gmail.com.
Dr. K, will we have access?
All right. Good afternoon. Dr. Kehinde Elisha speaking here, founder of NP Certification Academy. Today we're going to quickly go through some, little concepts that we need to know for the exam and how we should be studying and what we should have our head on. Now, I always say no strategy without content. Absolutely not. So the AANP exam, what does it really entail? So there are three major areas that we must know. The two treatments are psychotherapy. The second treatment is pharmacotherapy. And then we have to know our what? Our DSM-5-TR. That is not a given. We have to know it. And then apart from our diagnosis and DSM-5-TR, we also have to understand assessment. When we say assessment, is specifically psychiatric assessment. Okay. So how do we really approach these systematically so that we can hit it right on what they want us to do? It is using the what? The AANPPMHNP process. What is the AANPPMHNP process? It is the assessment. It is the diagnosis. It is the planning. It is the implementation. It is the evaluation. Okay? So if you don't know how to assess your patient, you will not be able to diagnose correctly. If you do not diagnose correctly, guess what? You will not be able to make an effective and efficient plan. If you can't plan properly, there is nothing to implement. If there is nothing to implement, the patient is what? Dead or no result. So assessment is a huge deal. You got to understand your assessment. The component, how do you collect data? Maintaining therapeutic alliance, what tools to use. Those are the things we need to know under assessment. What about diagnosis? That is your what? Your DSM-5-TR. That built heavily on your assessment. If your assessment is not detailed enough to collect the data that you need, there is no way to get your patient through. Okay, with that being said, we're now going to go ahead and introduce ourselves a little bit. Dr. Kehinde Elisha speaking here. www.npcertificationacademy.com is where to sign up. This is a paid review. And we also have expert courses for those that passed their board exam already. www.confidentprescriber.com. We have 99.9% pass rate for ANCC, PMHNP, and we have 100% pass rate for AANP, PMHNP. Okay, so you will pass your test as well. Now, the first thing that I want to have your head in is this. What is the overlap or what is the integration of family medicine with psych? And I will pinpoint exactly which area they're going to test you on the exam, but they will test you on it. They love to test you thyroid. For example, hypothyroidism look like depression. Hyperthyroidism look like anxiety. You have to watch out for those symptoms when you get to the exam. So let's look at this overlap quickly and get you all into clinical. That is what AANP is about. It's about clinical. Hypertension. What are the things that it can look like? Or what are the possible psychiatric diagnoses that can potentially actually comorbid with this? When people have anxiety, when people have depression or somatization disorder, you see, anxiety alone can increase blood pressure level because you don't think about it. One neurotransmitter is abundant in anxiety. It is norepinephrine. Does it make sense? So that is kind of the way to start thinking. And eventually, how do you want to manage that? You want to collaborate on stress management, use medications, whatever is making them have anxiety, we're going to try and deal with it. What about chronic pain, depression, anxiety, somatization disorder? Chronic pain can exacerbate mood disorders and vice versa. And we need to find a way to see the big picture that all these things interrelate. One can cause the other and vice versa. Use a multidisciplinary approach, pain management, antidepressants, cognitive behavioral therapy. What about diabetes mellitus? Depression, anxiety, eating disorders. Diabetes management can be complicated. We all know that. Diabetes can be complicated by mood disorders and eating disorders. When you have mental health disorders, guess what? You may just be eating incessantly. You may just eat and eat and eat and eat because of the mood that is off. At the end of the day, you get diabetes. Can you all see the big picture here? So we need to find a way to think like this on the exam and in real life too. Collaborate on glycemic control, support for mental health with therapies and medications. What about asthma? Panic disorder, anxiety. Asthma exacerbation can mimic panic attacks. Anxiety can worsen asthma. So coordination between managing asthma triggers and anxiety treatment. What about sleep disorders? Depression and anxiety and bipolar disorder. Insomnia often co-occur generally with mood states and mood disorders. Is either we have hypersomnia or insomnia when it comes to depression. So we got to do meds to kind of mitigate that, or we can use non-pharmacological alternatives. What about obesity? What about the possible psych diagnosis, depression, eating disorders? Obesity is often linked with depression and eating disorders. Management strategies: work on weight loss plans, encourage therapy for eating issues, and pharmacotherapy for mood disorders. What about gastroesophageal reflux, depression, anxiety? Are you supposed to be memorizing this? No. I just want to soak you in it so you can connect the dots on the exam. GERD can in fact worsen possible anxiety or depression, causing additional distress. You want to manage reflux with medications. You want to address underlying anxiety or depression with therapy. What about fibromyalgia? Depression, anxiety can be the overlapping diagnosis to see with that. Fibromyalgia is often comorbid with mood states and mood disorder. Can you see overlap here? Mood is a big part of everything that we do, and it goes on to post-stroke care, it goes on to pregnancy, postpartum care. And what I want to quickly talk about, that I want to emphasize quickly, is my thyroid issues. So let's look at this quickly. Hypothyroidism. What are the normal symptoms of hypothyroidism? Fatigue, low energy, weight gain, depression or mood, difficulty concentrating. Can you see how this is sounding so much like depression? That is why when your patient comes in and you actually pick it up that they have depression, also work them up for thyroid issues. Dry skin, dry hair, constipation, slow heart rate, muscle weakness or aches. What about depression? Fatigue or low energy, weight changes, often weight gain or weight loss, persistent sadness or low mood, difficulty concentrating or making decisions, decreased interest in activities, sleep disturbances, either insomnia or oversleeping, feelings of hopelessness or worthlessness, muscle aches due to emotional distress. So what are the overlapping symptoms? See, fatigue or low energy is looking like it's in both. You're tired with hypothyroidism. Also, you're tired with depression, right? Depressed mood, both hypothyroidism and depression can lead to feelings of sadness too. So the CG caps that we see with depression, we also see with hypothyroidism. That will be on the test, period. Okay. Now, the other thing you're going to also see on the exam is anxiety and hyperthyroidism. Now, what about the cognitive impairment? Brain fog or difficulty concentrating and thinking clearly is common in both conditions. What about weight changes? Definitely hypothyroidism. Can you all see my point now? Yes, we do have CG cap going on, but we need to focus mainly on what? We need to focus mainly on both and work them up. When you pick up depression, don't just sit in that bubble. You got to think out of the box and look at other things that it can possibly be so that you're not misdiagnosing and mistreating a patient. Does that make sense? I know we get busy sometimes too, but mastering our content right now before taking the board exam is also preparing us for the future. What are the key differences? Coding sensitivity, and dry skin, heart rate, weight changes. These are the things, constipation. So when you get to the exam now, when they give you key symptoms for anxiety, for example, I almost fell trap on that one, to be honest. It's going to be looking like anxiety. Your gut feeling just want to go straight and pick anxiety, but you're going to be wrong. You got to go back and reread it. If you don't see those symptoms for more than 6 months, you don't call it generalized anxiety disorder. You will not do that. And then vitamin D deficiency, what can it lead to? It can lead to fatigue, it can lead to low energy, depressed mood or sadness. We can see muscle weakness or aches, bone pain, difficulty concentrating. We can see sleep disturbances and reduced immunity. Depression symptoms, persistent sadness or hopelessness, fatigue or low energy, difficulty concentrating, sleep disturbances, decreased interest or pleasure in activities, feelings of worthlessness or guilt, appetite changes, either loss of appetite or overeating. And then we have the overlapping symptoms. That's pretty straightforward. Like, anemia is also one thing, but of course, you really won't get anemia. But anemia is not so a family medicine concept that kind of overlaps with what we do. What do we see with anemia? Fatigue, weakness, pallor, dizziness or lightheadedness, and so on and so forth. And then we also have depression symptoms, persistent sadness or hopelessness, fatigue or low energy, difficulty concentrating or making decisions. Of course, we have sleep disturbances. We have decreased interest in activities. We have feelings of worthlessness or guilt, appetite changes. Overlapping symptoms, fatigue, anemia. Fatigue or low energy, both anemia or depression can cause significant tiredness and lack of motivation. So that is why a thorough workup is important to pick up on what is not, and you can see it's just talking more about the overlapping symptoms. It's talking about hyperthyroidism, and then we're now on panic disorder symptoms, sudden unexpected intense fear or discomfort. And that's one thing I want to quickly talk about right now briefly. When we talk about the panic attack and panic disorder, what is the difference? Don't forget, panic attack will come, boom, and goes. Panic disorder kind of lingers and it has other things attached to it. That is panic disorder. You have to know the differences, understand it very, very well. Exam is not an entry-level exam. They are testing you things that are frequently seen and that you should know. You're expected to know as a provider, but they are not taking things from the high level. For example, too, we're going to talk about first-line medications and some basic diagnosis. And see, this is all actually, pretty much done. The overlapping symptoms are so obvious, except maybe we should go ahead and talk about ADHD a little bit with ASD. Okay, before I get to the end. So let's talk about that a little bit. Okay, this social anxiety, I'm just skipping all of those. Let's talk about ASD. So ASD, what is the main symptom of ASD? Social communication changes, repetitive behavior, interest, sensory sensitivities, cognitive variability. And then look, social communication changes, difficulty with verbal and non-verbal communication, gestures, eye contact, tone of voice, limited or absent back and forth conversation, difficulty understanding social cues. That one is very, very prominent. Okay, facial expressions, body language, challenges forming or maintaining relationships. And then we have the repetitive behaviors and interests. Just get stuck on one thing, like hand flapping and rocking, becoming upset with minor changes in routine, intense focus on specific topics or interests, often to the exclusion of other activities. Sensory sensitivities, hyper or hyposensitivity to sensory input, light, sounds, textures, or smells are very, very common for these folks. Overreaction and underreaction to pain or sensory stimuli. Cognitive variability, intellectual disabilities may occur, but not all individuals with ASD have cognitive impairment. So let's take a look at the ADHD, because they tend to kind of overlap, and that's one thing with ADHD. At what age do you, according to DSM-5TR, should you be diagnosing ADHD? Can you drop your answer in the chat? Around what age are you expected to diagnose ADHD? Let's not forget, it's going to be age 12. That is very, very, very important. You have to know it for your test. Okay, so now, inattention, hyperactivity, and combine. Inattention, difficulty sustaining what? Sustaining a task or play. In difficulty sustaining a task or play. What about easily distracted by extraneous stimuli, frequently forgetful, losing items, unnecessary for tasks, difficulty following through with instructions or completing tasks, hyperactivity, excessive fidgeting, squirming, or difficulty staying seated, running or climbing in inappropriate situations, difficulty engaging in quiet, calm activities. Impulsivity, just, they can't wait their turns. They interrupt people. Executive functioning difficulty on time management. Most of us do these things, and how you're gonna know for sure is you're gonna be like, okay, what is the chronicity? How often do we do these things? That is the way to know if we really have a problem with it or not. And then the overlapping symptoms is gonna be like both ASD and ADHD. They may involve social difficulties. Children with ADHD may struggle with impulse control, leading to interruptions in conversations. They have difficulty maintaining social relationships. While children with ASD often struggle to interpret social cues and engage in reciprocal communication. ADHD is just the opposite of that. What about impulsivity? Children with both disorders may act very impulsively. However, ADHD impulsivity is often more about acting without thinking or interrupting people. So the impulsivity varies with both, whereas ASD, that one can come with rigid behaviors and they don't want to make any change. They are so resistant to change. That is where, or that is how they come out. A lot of people actually have both conditions and they don't know it until they get to adulthood. What about attention problems? Both conditions may involve attention difficulties. Children with ASD may appear inattentive due to what? Their intense focus on specific topics, making it difficult to shift attention to other tasks. While children with ADHD may struggle to focus due to distractibility. Restlessness. Both conditions also involve restlessness. Children with ADHD may display physical hyperactivity, fidgeting, inability to stay seated, while children with ASD may become agitated or anxious in unfamiliar or challenging environments or changing environments. Any kind of changes just tend to affect them really bad, and it may manifest like restlessness or repetitive behavior. The key differences will be social interaction, of course. ASD with autism, they have core difficulty in understanding social interactions. They often struggle. They just can't connect with social cues. So you will find out people around them is, how is he acting like that? How is she acting like that? Sadly, they don't connect with it. They don't even realize it. Okay, so people around them, if you get upset, you're only getting upset for nothing. Doesn't make sense because they're not aware of it. This makes it challenging to form relationship because they cannot understand the emotion of other people. And that is a big deal right there. Now, ADHD may have social difficulties as well, but they are usually due to impulsivity. That means they just interrupt conversations, they blurt things out, they speak out whatever is on their mind, just anyhow like that. They are not focused, they don't pay attention. You gotta know there's a lot of autism and ADHD questions on the exam. They like these two topics a lot, so just make sure you understand some of it. They also like suicide. There's a lot of suicide questions too. We're going to be going through suicide tomorrow, so we can tackle that once and for all. Now, they can generally form a relationship but may struggle to maintain it because of their behavior. So people don't like to be interrupted. People feel disrespected about small things like this, but they just can't help it. And that's where we have to come from, the angle of compassion. When you know what somebody have, they didn't create their own brain. They didn't create the chemical. So we need to show some understanding. That's why I tend to actually target this very population in my review. I'm particularly interested in this population because I do know there are challenges that they just can't help, and that shouldn't stop them from getting through life like other people. Focus and attention. ASD children with autism often have intense focus on limited range of interests like trains, numbers, specific topics. They may struggle to shift attention to other tasks. People with ADHD, on the other hand, they have, they struggle with sustained attention across a wide range of tasks. So they may jump from this task to that task and then pump on another one behind them and in front of them and underneath their feet. Like they just have a trouble that way completing tasks. They just start something, they never finish it. And it's not, sometimes they also hyperfocus, but they don't really hyperfocus on mostly, but they do sometimes with something that have fixed interest for them. Behavioral rigidity versus impulsivity. People with autism, they may display rigid behaviors and insist on sameness. That is a classic trait of autistic person, such as needing to follow the same routines every day or becoming distressed if change occurs. They also may engage in repetitive behaviors such as hand flapping or lining objects up. ADHD children with, they may be impulsive, acting out without thinking about consequences, but may struggle with self-regulation. Their behaviors are often more spontaneous and reactive compared with somebody, with rigid behavior like autism. Sensory sensitivity. Sensory sensitivity is a hallmark of autism kids or adults. Let's not forget the same kids will grow up to be adults. We have so many undiagnosed autism, you don't even want to know it. We have so many undiagnosed ADHD, you don't want to know it. So children with ASD may overreact to sounds, light, textures, taste, smells. They, like when we say overreact, overreaction, okay? And this is tough for those around them too, because you don't smell anything, you don't feel anything, you don't hear anything, but they're hearing it all. So, it's just a different story on its own. Now, what about ADHD? Sensory sensitivities are less common in ADHD, although some children may experience sensory overload due to their distractibility or hyperactivity. Now, you're trying to do gazillion things, and somebody's like whining here, crying here, and screaming here. They are like a little thing will get you distracted. The distractibility is the problem for ADHD. What about language development? ASD language delays often, or differences in speech patterns, echolalia, lack of conversational reciprocity are very common. Some children may not develop speech at all, while others may have advanced vocabulary but struggle with pragmatics, like the social use of language. Where ADHD, they have language development and is typically age appropriate in ADHD. However, children with ADHD may talk excessively or interrupt others while speaking. And that is pretty much it for that. So we need to also know that for ADHD, we can use O'Connor's rating scale. For autism, we can use A-G. What does that mean? Autism diagnosis observation schedule. We can also use autism diagnosis interview revised and developmental history. It's typically diagnosed in early childhood. So how do we manage both conditions? For ASD, treatment is centered mostly on behavioral therapies, applied behavior analysis, speech therapy, occupational therapy, social skills training. Medications may be used for co-occurring issues like anxiety or aggression. ADHD, on the other hand, the treatment often involves stimulant medications, e.g. methylphenidate, behavioral therapy, or parent training to help improve focus and impulse control. Other medications like non-stimulants may be used. Now, co-occurring ASD and ADHD can occur together. Very, very possible. It is not uncommon for children to be diagnosed with both conditions. When this happens, treatment strategy may address both rigidity and focus associated with autism and impulsivity and inattention that we see with ADHD. So I cannot imagine what the kid goes through in his head to have this condition at the same time. I just cannot imagine, or an adult that was diagnosed with it. It's got to be very, very difficult. So these are kind of some concepts that are very, very high that I just went over. This is not my entire DSM. My entire DSM is another ball game. But now we're going to be doing some last minute review, like questions, and see how that goes. But do we have any questions? Speaking as Dr. Kehinde Elisha, founder of NP Certification Academy. To reach us, nurse2nursecoach@gmail.com and or www.npcertification. Just go to our website. You're gonna see my contact there. We have Facebook, we have YouTube, we have LinkedIn, we have all that stuff. Just look us up there and connect better with us. Thank you. Hello, Dr. Kehinde Elisha speaking here, founder and CEO of NP Certification Academy. Today we're doing a little free review to show you how to really think through the exam, especially when it comes to diagnosis. But we have to keep in mind that there are no strategies without content. So the very first thing we must have down packed is what? Your content. If you don't know your content, how do you recognize the key symptoms, the keywords to be able to nail the right diagnosis? And let's not forget that the AANPPMHNP process applies when we are diagnosing. That is the assessment, the diagnosis, the planning, the implementation, and the evaluation. That's something you're going to hear me talk about a lot. Because if we don't assess our patients correctly, guess what? We're going to misdiagnose them. When we misdiagnose them, our planning will be off. If our planning is off, what are we implementing? Nothing. So everything builds upon assessment. So we have to see each of these as a subject and deal with them just like that and have a good understanding of them. So now, what are we going to be doing today? We're going to be looking into test taking strategies for a case. I think I will just take a case and walk you all the way down to show you how to really analyze questions, to see you what one question can potentially contain, to see you why strategy is just a gimmick, to see you why strategy may never work without content. There are no strategies without content. Absolutely not. Dr. Kende Elisha speaking here again. I'm reintroducing myself. We're now going to get started. A 25-year-old keyword, male, present with what? To the clinic with complaints of what? Not sleeping for the past 6 nights. Male is a keyword. The setting is a keyword. And that is the clinic. Listen, an ER is not a clinic. Does it make sense now? Acute care setting is not a clinic. So the setting matters. You have to know your setting to be able to understand what you're dealing with and how to understand what is in your hand. Not sleeping is a keyword. The past 6 nights is a major keyword right there. Claiming he feels great and doesn't need sleep. See, and that is a major keyword. I feel great, I don't need sleep now. So night nurses, don't start thinking that you have this issue. I'm not going to say the name, because as a night shift, I used to be a night shift nurse too. I feel tired after so many hours of not sleeping. This person is been up for 6 straight nights and is not tired. That is a problem, guys. Now, he is overly talkative, jumps from one idea to another, and describes himself as a future billionaire. Despite having no clear business plan, he maxed out his credit card, buying luxury items he cannot even afford. He has no history of substance use. Those are all keywords too. And family reveals that his mother has been diagnosed with bipolar disorder. Now, that is what stylishly introducing genetics. So which of the following is the most likely DSM-5-TR diagnosis? A, bipolar 1 disorder. B, bipolar 2 disorder. C, cyclothymic disorder. D, schizoaffective disorder. Now, let me tell you something about this question. First of all, it's thick. Thick, man. Now, let me tell you, a question like this, what do you want to do? You want to, probably, I would say maybe if it's going to take you more than a minute, go ahead and flag it and keep it moving. As you keep it moving now, you're going to see like 1-line question, 2-line question. You want to save that time and slap it on top of this one, especially if it's going to take you at least 1 minute and 30 seconds. Now, for every question, you don't have 1 minute, 30 seconds. Now, even if your question is 1 line, it is still the same grade, right? So my point is you can always save on those little tiny skinny questions and dump them on the thick questions. So in any case, let me say, ideally, you must be able to read this top for 30 seconds. You must be able to read the bottom 30 seconds. By the time we had it up together, it's going to be 1 minute. So are you able to keep up with that? If you cannot, don't forget, they have accommodation for exams. You can always apply for extra time if you need it by contacting what? ANCC, or by contacting AANP. They do have accommodations if you qualify. Not everybody get extra time, but they are very generous and fair as long as you have the reason to get extra time. So please drop your answer in the chat. What do we think here? Now, after reading your question, after reading your keywords, you're going to go back and do what? I'm going to say, okay, 25-year-old male, clinic, not sleeping the past 6 nights, feels great, doesn't sleep, overly talkative, jumps from one idea to another, future billionaire, having no other business, no clear plan, so lost. It's a difference to say, okay, I'm going to be a billionaire in future. It's different to be so clueless and lost. You don't even have any plan. And there is no, it's not looking good because you don't have anything to say, okay, this person can really achieve it because of X, Y, and Z. There is no way to nail all of that. Now, he has no history of substance use, and family history reveals that his mother has been diagnosed with bipolar disorder. That's a major family history. Don't forget. I will quickly drop in some content here. We have what? Bipolar disorder. When we talk about bipolar disorder, there are types of bipolar disorder according to the DSM-5-TR diagnosis guide. We have what? Bipolar 1, bipolar 2. We have hypomania. We have cyclothymia. Now, bipolar 1 goes on for 1 week. Listen, of what? Irritable mood. What do we see? They have all these dick fasts. They can most likely, they're going to have this manic phase. This manic phase is about to set in here, or is setting, it's getting close. They are already past 6 nights. For the past 6 nights. So in 1 more day, patient will be what? I know this one is a little vague, right? But in one more day, do we call it bipolar 1? Let's look at the content behind bipolar 2. With bipolar 2, we're going to call it two poles. What does two poles mean? Two poles mean we have what? We have major depressive disorder, and we have what? Hypomania. Like, what in the world is hypomania? It's simple. Don't forget, in your mind, go ahead and sketch a graph. This graph is called a graph of life. In our life, our mood can either be up in the roof or our mood can be down in the dump. This is our life, including me, including you. Let us all be honest here. We all don't have happy days. Things happen. You just got married. You're so excited. You're going to get up to the roof. Now, when you stay glued to that roof for more than 7 days, it is something else. It is not because you just got married. We're going to call it what it is. We're going to call it bipolar 1, period. Right? Now, when something terrible happened to you and you are down in the dump, looking all sad and teary, you know, and it just feels so down, and you're hanging out here for 2 weeks, guess what we call that? We call that MDD. We call it what it is. And that goes with what? Sig caps. Like, what in the world is Sig caps? It's just a mnemonic. You can come up with your mnemonic. Sleeplessness, interest loss, psychomotor agitation or retardation, guilt, hopelessness, worthlessness. Those are things we see with depression. Listen, in real life too, when somebody is up here and glued to the roof, we can do what? We can psychopharmacologically or psychotherapeutically pull them back down to this graph line right here. What do we call this line again? We call it, I don't think I told you. This is called the euthymic state. Now, the euthymic state is where we all want to be. Is the happy, jolly state. Life is good. Life is perfect. There are no bumps on the road. There are no bumps on your path. Life is just going smoothly. Nobody stays here. Nobody lives here. However, we need to return here once in a while, though. Does it make sense? And most often than not, we want everybody to be able to return here. Now, if you cannot return to the euthymic state by yourself, that is when we do what? We have to physically give you medication and pull you down here to the midline, or use a talk therapy to pull you down here. Similarly, if you are getting like down and you are down in this dump and you can't rise anymore, we have to pharmacologically pull you up to the good state, or we're going to go ahead and do what? Use words to help you out. But then to know what we're going to do too, that's when our scales comes in. If you're depressed, we're using what? We're using the PHQ-9, for example, to see where you are. If your number is so high on the scale, we're going to send you to, a clinic or something like PHQ-9 of 27. We have to do something about it. We can't just talk you out of that level of depression. If your PHQ-9 is mild, we can definitely do some therapy and get you out of that state over time. Now, let's get back to this question now. So I just feel like I should throw that content in there so it's going to make some sense. So now this patient, based on my little graph right here and my analysis, I'm going to go ahead and label this graph for more clarity. This is getting to a manic phase. This is bipolar 1. Below bipolar 1 is called hypomania. Hypomania is right below the manic phase. Below the hypomania is now the euthymic phase. That is the straight line that we all desire to be. Now, we are not all there, but a lot of times when we get down on the dump or when we get to the top of the roof, we can find our way back up by ourselves. It is only when we cannot get up or come down by ourselves, that is when we need help. That's when they need our psych MPs, right? Or our therapists or social work and stuff to get us the services and the support that we need. Now, below the euthymic phase, when it's getting down here, that is where we have our depression. Depression, somebody that is down in the dump. Most importantly, you must recognize the symptoms. They will not give you this content on the exam like this. They will not call depression. They will describe the symptom and expect you to know it. The only way to know it is to tap into what is up here. The brain is like a computer. You can only tap into what is there. There are no strategies without content. Absolutely none. Dr. Kehinde Elisha speaking here, founder and CEO of MP Certification Academy. To really connect with us and be in our circle, visit www.mpcertificationacademy.com. Don't forget, after you pass your board exam, guess what? We're going to add you to our expert group where you're going to continue to collaborate with other providers like you. We have more than 3,000 members. so far that are interested, but our WhatsApp is getting full, so we should be changing our platform soon so that we can have all our providers in there. A lot of people also are not comfortable being in WhatsApp, so we only physically have almost 1,000 right now, so we are getting maxed out in that WhatsApp. The max is supposed to be 1024. So what is my point? My point is, you got to be in that circle that when you pass your board exam, you won't just do what? You won't just be by yourself trying to navigate the world. You're going to be with the next phase and then collaborate and network yourself. Not that we do anything special for you. I'm not going to make any promises that I can't fulfill, but you will be in the right circle of people that are progressing. You will be in the right circle of people that are already ahead of you. They have their own clinics, and they can also help you navigate if you're interested in their in how they get there. So, and on Thursday night, we also meet every Thursday to help serve our expert community. We go through case studies. They bring their clinical cases. We all brainstorm together and guide you through life. So you are never going to be alone. For our experts, just visit www.confidentprescriber.com. www.confidentprescriber.com. Now, back to this question. What is the final answer? The final answer is what? Bipolar 1 disorder, period. This is getting to a manic phase if you can see it. Bipolar 1 disorder, period. Let's see how to, let's look at how we navigate, how we came up to that conclusion. This is how you should be analyzing question on the exam. This is how you should be thinking. Step-by-step analysis. Sleep. No sleep for 6 nights. It is concerning. This is a manic episode. Reduced need for sleep is very, very big. That is the hallmark for bipolar. Mood and behavior, elevated mood, grandiosity. I am God. I know Jesus. I saw Jesus last night, not in my sleep. In real life, I even shook hands with him. I'm going to go meet with the president and so on. Like, those are grandiose thoughts. Pressure speech, impulsive or risky behavior. Functional impairment, like spending and behavior, how clear, functional impairment satisfying DSM-5 tier criteria for mania. What about duration? It's more than a week. That's the main thing. It has to be 7 days. How will I remember that? Bipolar 1. Okay, when you say 1, there is 1 week. 1 week is equal to 7 days. So that will help me remember what? My 7 days. But you have to remember your symptoms. The mnemonic for your symptom is mostly what? Something we call dig fast. Listen, the mnemonic for, depression is going to be what? Psychic apps. Now, rule out other diagnoses though. No depressive episode. Rule out bipolar 2. Make sure there is no psychotic symptoms apart from grandiosity. No schizoaffective. No 2-year duration of ups and downs, not cyclothamia. So you're going to be ruling out other things because these things tend to overlap. Now let's look at the rationale for why we picked A. It's A because what? Bipolar 1 meets DSM-5 tier criteria or manic episode, elevated mood, grandiosity. Again, based on the explanation that we just gave. Bipolar 2 disorder requires hypomanic episode, plus major depressive episode. When I say bipolar 2, 2 poles, that's what I mean. Hypomanic is 1, MDD is 2. That is 2 poles. Bipolar 2, 2 poles, right? Now, cyclothamia requires more than 2 years of fluctuating what? Subthreshold depressive and hypomanic episode or symptoms. This episode is too severe and acute for cyclothamia. What about schizoaffective disorder? There is no persistent delusions or hallucinations for more than 2 weeks without mood symptoms. Grandiosity alone does not meet psychotic disorder criteria. If you are my regular student, this is not the full review. This is only one diagnosis out of like more than 50 diagnoses that you have to know for tests. So you are in a safe place if you're already enrolled with us. If you have yet to enroll with us, I can't really promise that this is going to be anything. That this is not everything. There's a lot more to learn. Visit www.npcertificationacademy.com. We're now going to stop here right here. I'm now going to throw in some content on critical thinking application of neurobiology, DSM-5 TR, as well as psychopharmacology. Thank you so much, but I'm going to be terminating this right here because it's already at 15 minutes. Have a wonderful day, everybody.